Good evening, everyone, and welcome to the third in the series of the Dental Dean's webinars. We've had a superb attendance this evening in terms of registration, and we're not quite sure whether that's the popularity of our webinars or whether it's actually the topic, perhaps, looking at the future and the challenges ahead. Because I know there's certainly a lot of anxiety, a lot of concern out there about what the future holds. And people are desperately looking for answers to many, many questions. I can't promise that we will have answers to all these questions, but we've got an excellent panel this evening who are very well informed, and they're going to share their knowledge, expertise and experience with you this evening. I'd like to welcome to our panel Roshni Karia, who is the Vice Dean of the Faculty of General Dental Practice, Andy Edwards, who is the Dean of the Faculty of Dental Surgery in Glasgow, Albert Long, who is the Dean of the Faculty of Dental Surgery in Ireland, Fraser MacDonald, Dean of the Faculty of Dental Surgery in Edinburgh, and Mike Escudier, who is the Dean of the Faculty of Dental Surgery in England. So, well, thank you very much for all of you, and again, I think we all appreciate how difficult the situation is for everyone at the moment with COVID, and we're all desperate to get back to work. But clearly, first and foremost in our minds is around safety, is supporting our patients and the wider community. And in the first couple of webinars, we had an update initially on the first webinar, and the second one we looked at urgent dental care. And I think we have seen progress across the UK. And as we're getting closer to perhaps relaxing the lockdown, we're looking at the future. What is going to happen over the next few weeks and months? So I think it would be useful to go around the panel and maybe to ask each of them to identify the specific challenges that they see in the weeks ahead. And I'm going to turn first to Fraser. And Fraser.
Sorry, so just a bit of housekeeping for those listening. Thanks, and you may not believe this, but we've had a lot of help from the General Dental Council, and they've given us permission, provided we actually identify the topics we're covering, that you will get CPD for this hour. So I've got to listen in and take notes exactly where it is and map it to the document as provided by the General Dental Council, and you'll get that information after the webinar some point afterwards. Thanks very much, Ian.
Okay. Did you want to come back on the specific question around what you see as the specific challenges?
Being a gentleman from Scotland, I always prefer ladies to go first.
Well, that would be Roshni then. Roshni, can I pose that question to you?
Thank you, Ian, and welcome to everybody that's logged in this evening, and for all the questions that you've given us today. Going back to the question that Ian has just asked, I think at the forefront of all of our minds is obviously safety, but also the sustainability of any protocols and guidelines that we do have to implement, particularly in a general practice setting. But going on beyond that, I do think one of the biggest challenges that we will have to face is restoring our patients' confidence back into dentistry once again. Because regardless of how perfect our protocols may be, we need to make sure we have our patients there confident and ready to come back to practice, and ready to give them the oral health care that they need and deserve to help reduce the oral health inequalities that may be starting to emerge, but also restore their faith back into healthcare as a general as well. So I do think that one of the biggest challenges will be restoring our patient confidence, as well as for ourselves, learning to slow down and respecting each other and each of the challenges that we may face as a whole team. I think everyone has different challenges at this stage. Neither are bigger or smaller, they're just different. And I think we need to just learn to understand that each of those challenges will vary. Our attitudes to risk and the financial pressures that face us will vary between ourselves. And I think the quicker we understand that from each other, the quicker we'll be able to ease ourselves back into some sort of normal as we return back to practice.
Thanks, Roshni. Andy, you fancy sharing your thoughts?
Will do. Thanks, Ian. Yeah, hi, good evening, everybody. Obviously, the colleges, they're mainly concerned around education and assessments. And I think, looking forward, that the challenges that certainly we face as Royal Colleges is trying to deliver these examinations, the assessments and education. And certainly we'll be looking at different ways of delivering these things now. And I think we're all used to now, certainly I am, used to the technology that's available. And I think that's going to be a big factor on how we do it. And there'll be a lot of delivery of, particularly from education from home. The days, I think, of people traveling to conferences and that will still happen, but I think a lot of it now can be delivered within the home environment, within the practice environment, within the dental team environment. So I think all the colleges are looking at ways of delivering it, and it is a challenge for us. The second thing, and I'm sure Mike and Fraser and Albert will come in on this, is how we deliver our examinations going forward. Obviously, we've had to curtail a lot of examinations. I mean, in our college, we've had to curtail 68 examinations, and about 1,500 trainees have been affected, right through medicine, surgery, and our dental colleagues as well. So it's had a massive impact on training and how we deliver our examinations. It's something that we're going to have a look at, and certainly in the future look at novel ways of deliver that. And I'm sure possibly Mike and Fraser will probably come in on that.
So thanks, Andy. And I know that over the last few webinars, we've generated quite a few questions around how this will affect training for those either at undergraduate level, those that are going through dental foundation training, and those in specialist training. And perhaps Albert, Mike, or Fraser would maybe just reassure those that are listening that there is a lot of work going on behind the scenes to try and limit minimize the problems that may cause.
Yeah. Good evening, everybody. I think in terms of the first question that Ian posed there, I think that the preparations of coming back to work, what the new normal is, and what the risks are in relation to primary care, secondary care practices, what the patients are expecting from us, what we can deliver against the unknown of the disease pattern happening, the risk that is involved, and potential of it coming back again in the winter time against government policies of lockdown and the removal of the lockdown policies against the finances are the ones that a lot of people are very concerned about. Things are not very clear, and there's no clear answer, and we don't know what the clear answers are in relation to that. And it's probably why one of the main reasons why in relation to our seminars and our webinar that there are lots of attendees, which we're very grateful for. In relation to assessment and examinations, as Royal Colleges of Surgeons, that we are all to do with educations, assessments, and training, and we're all aware of the challenges that is faced by a lot of the candidates, by the examiners, by organizations, because examiners or examinations have ground to a halt. And in relation, and also echoing what Andy Edwards suggested as such, that we're all doing our very best to try to restore some kind of normality and restart some kind of assessment as soon as we practically can in relation to a lot of the trainees, so that career-wise you can still move on, and training-wise you can still receive those and be able to examine according to all the intended learning outcomes, assessment method that we have, while we still deliver a robust assessment there for you. No easy answers, but we're trying our very best what we can do.
So that leaves me. So I think one of the things that we face going forward is it's balancing the wishes and needs of patients and the profession, be they trainees, practitioner, consultants, against the needs of controlling the pandemic. And that's really one of the great questions. Is obviously the lockdown was imposed in order to try and reduce the rate of transmission within the community, and it has been successful. There isn't a lot of headroom at the present time, and so I think the government of England have announced that they will make a pronouncement on the plan this Thursday, and it will be interesting to see what measures they think they can, if any, relax at this stage. Where healthcare will sit within the plan for the England in terms of relaxation, I'm not privy to, and I'll be interested to know. But that's the challenge. How do you reopen access? How do you reopen activity in any sphere, be it dentistry or be it the high street? And what effect will that have on the infection rate within the community? And therefore the potential for, in this case now, a second peak. And what we'd like to do, of course, is avoid a second peak. In terms of education and the assessments, I think there are three elements to that. There's the entering, and I think the relative, be it CopDend, NES, HEE, have been very active and effective in actually putting in place a process that will enable both trainees to exit from undergraduate training and to enter specialist training or non-specialist, be it DCT or NTN specialist training in the coming months. At the other end, as Andy's spoken of, there's the Royal College exams, which we have an opportunity to look at revising in order to be able to deliver those in a different format, which would be to the advantage of all parties, all stakeholders. There's then the issue around actual training as it's going on. And I think, again, that will be a challenge and an opportunity in equal measure, as it will be for postgraduates and undergraduates. How do we progress that during a period over the next 6-9 months, perhaps even a year, when we have to operate in different ways? But it's a challenge to which many of the postgraduate institutions are rising in terms of the way in which they deliver training, both through simulation and online at the moment.
Thanks, Mike. And Fraser, you're closely involved with Orthodontic postgraduate training, and they comprise the greatest number of specialists in training. What are the specific problems that you are seeing in terms of the continuation of that training?
Well, no, I'll come to the training bit in a moment, because the overview, if you look at, we're talking about the colleges and the universities need to change their views to assessments. Actually, the Open University has provided remote assessments for many years. So it's just that everybody else seems to be catching up with the Open University. But the main thing is we're starting to see slight glimmers of light at the end of the tunnel. So certain countries are opening up one or two parts of practice. I spoke to one of my colleagues today. Germany, Switzerland and Australia already starting to open up practices to orthodontics at the moment. But there are very specific guidelines. And it's very clear, I'm not saying that England is ready or United Kingdom is ready to go back to this, because the profile of the disease in each country is very, very different. Australia have hardly had as much lockdown in certain states in Australia as we have in the United Kingdom. But one of the other big issues, and I'm sorry to be slightly pedantic in this, we're talking about getting the workforce back to work. I'm thinking about how you actually get the workforce into work, because currently in London, the current state of rush hour is not compatible with preventing spread of the virus. So we're going to have to go through, the government, the country, and all of us are going to have to think about the strategy of how we travel to work in the future, as well as when we're at work. And going on to the training, saying there is a lot of work going on is an understatement. People are looking at the traditional layout of dental hospitals and just trying to work out how we can actually have aerosol generating procedures in one bay and then still have the bay next door being delivered for some other assessment. So there's a huge amount of work, and we have to be guided by the overall United Kingdom view as to where we should be with regard to whether we can go back to work. So there's a huge amount of challenges, not just in the dental surgery, Ian.
Thanks, Fraser. I think that's a point that we haven't really highlighted in the previous webinars. And I'm aware that a question came in earlier, I think it came in yesterday, about that specific point, about regional variation of rollout, and should that be risk-based? So I'm based in the southwest, in North Devon, and congestion and transport isn't an issue because we haven't got any transport. So there are very different problems in rural areas than there would be in central London. So yeah, I think that is something that needs to be discussed if it isn't being discussed already, and for us to be prepared for that rollout. But, so in the background, we've got Simon Thornton-Wood, who's the director of the Faculty of General Dental Practice, and he's going through the questions that are coming in from the participants. And Simon, if I can go to you, and what are the top questions at the present?
Inevitably, Ian, there's a host of questions around aerosol control. Can you hear me? Can you hear me? Hello?
Yes, yeah.
Good.
Yeah, we can hear you, Simon.
Inevitably, and there's been a host of questions around aerosol control, and not just about PPA, not just about AGPs, but around external venting, air purification. A lot of people asking about where the standard operating procedures are going to come from, and maybe you could tackle that, the generality of those aerosol control questions.
Okay, thanks, Simon. And certainly, I think in the previous webinars, the focus was very much on what is an AGP or an AGE and what isn't. And certainly in the last couple of weeks, although there's still, I would suggest maybe a bit of a lack of detail or evidence to underpin the risk of particular procedures, we have moved on to beyond just the FFP3 masks, but actually how are other ways that we can reduce the risk. And certainly, judging by my inbox in the practice today about the number of companies that are offering me air ventilation systems, that's clearly one method which is being explored. And I just wondered what the experience is of the panel in terms of the risk related to AGPs and how we can perhaps minimise that risk. Andy, if I come to you first, because I know that the BAOMS and the BOS were quite clear with the guidance that they set out a few weeks ago.
Yeah, thanks for that, Ian. Yeah, the BOMS and BOS were very
Andy,
they were very stringent about their guidance and that when it first came out. Yep, you can still hear me, yeah? Hopefully. Yeah, the BOS and the BOMS have been very stringent in their guidance that came out, basically. But as you say, we've seen a lot of information coming out, basically, around about AGPs and around about masks and that. I think just a word of caution here. As you know, there's been a host of companies jumping on the bandwagon, offering everything from foggers to UV light to air purification systems to all sorts of various types of things to try and filter air and that. And I think we've got to be very, very careful how we go about this. You mentioned guidance. Just today, the 4 CDOs have commissioned, or I use the word commissioned, that SD-CET are going to do a rapid review of looking at getting back to practice, and they're going to look at it in the international arena. There's a lot of evidence out there. The American Dental Association have already published a toolkit about getting back to practice. We heard about, Fraser talked about the Australian picture, which is diversely different from ours. They've also talked about some guidance as well. So what SD-CET are going to do is to collate all the guidance that's out there in the international arena so we can come to have some joined up thinking here and joined up guidance across all 4 nations. And that way it will stop people going out and buying things unnecessarily with regarding a whole host of things, because it's expensive. It's very, very expensive. And the way we do dentistry going forward, it's not going to be the same as we're doing dentistry today, basically. Regarding the AGPs, if there's a plethora. I mean, my inbox, like your inbox, is I'm getting papers on papers about FFP3 mask, FFP2 mask, what's an AGP, what's a non-AGP yet, and you just have to be quite pragmatic about it. It's all about risk assessment and mitigation, basically. What you consider to be a risk, then you basically mitigate against it. And if that means wearing full level 3 PPE, then wear full level 3 PPE. I don't know what any of my colleagues can think about that, but that's what my own thoughts are.
Yeah, if it might be possible that I'll come in on that. Thank you very much. I think that I think that Andrew has hit the issues right on the nail as such. That it is very difficult. We're looking about risks here. All the measures that we have at the moment reduces the risks. It's accumulation of them that makes a difference as such. I mean, one good incident, say for instance, is that air purifications. Some of the companies may claim that you've got a 99.99% filtration on it. But if you look at the increase in the viral loading in terms of infectivity of COVID, which is sort of 10 to the power of 6, 10 to the power of 9, a reduction of 99.99% is still elevated the infectivity by about 1,000 times. So you're not apparently making a huge amount of difference. So like scavenging the system, external venting that will do. The instance, say for instance, I mean, I'm not talking from the Irish experience, I'm looking at my other role at the Eastman Dental Institute, where we have a new facilities at the moment there. The requirements for external venting for the newest equipment or newest facilities is that you need to churn the air over about 12 times an hour, which is very, very onerous and still will be reducing the risk. When you're looking at things like rubber dam placements, high volume suctions, mouthwash just from the patient, so they all will reduce the risk. As far as literature is concerned, the only one that I'm sort of aware of there as such will be the systematic review from Greenock, from Woods, and there's another article relatively recently which suggests that if you use these combinations together, whether you use phase 2 or phase 3 sort of protection, you're going to reduce the risk by about between 99.99% to 99.995%. But the question we ask is that if this reduction of risk is that sufficient, is that enough? I mean, we haven't even got that answer there. So it's very difficult to say, oh, this is a definitive answer to that. We're just minimizing the risk to our patients, doing our very best at the moment with it, where the guidelines evidence comes out.
Thank you. Roshni?
Sorry, thank you. And I think the points so far have been very well made. I think the other important thing to remember is that, of course, safety, risk assessment, and the evidence is, of course, very, very important. But from a general practice viewpoint as well, some of these things, as Ms. Edwards said, is very expensive, and we have to think about the sustainability of some of these practices who are already struggling financially as to whether this kind of equipment is going to be something they can afford. And we have to be very careful that if there is guidance that emerges then that we do need these, how are we going to support the practices in order to have this equipment and keep it safe, not only for themselves, their teams and their patients, and how dentistry will sustain itself in the long run. So of course safety is important, but I think there has to be a fine balance between its sustainability as well.
Thank you, Roger. I think there's a delay on my line, and perhaps maybe it's being in deepest, darkest Devon, so my apologies. Mike, can I go to you, please?
Yeah, I think one of the things to think about is, Roshni already spoke about it, is you need to risk assess your patient, but also not just risk assess them in terms of the risk to other patients, but also the risk to them. I'm minded that there's a significant number of people in this country who are shielding at the moment, either because of their age or because of a medical comorbidity. We need to think about, is actually coming to have dentistry for them at this time or going forward, is that in their best interest, depending on what the pressure is. There's also, whilst we can talk about things like new technologies, I don't think we should lose sight of what's been our standard practice in terms of infection prevention and control, in terms of keeping your surfaces clean. And as we move forward, in terms of things like social distancing for your staff in your surgery. Quite a lot of the risk zone in hospitals around the world has been when staff have actually been in their downtime. It's actually been when staff have not been actually seeing patients on wards. It's been when they've gone to the coffee room and they've all sat next to each other. So I think it's important that we start to consider what are all the implications. How can we bring to play what was already our mainstay of infection control and really do that well? So we have to do that really well, and then there will be some other things that we can perhaps add on, such as you've described. And that will come up, as people have said, it needs to be evidence-based. We need to have good guidance on what is and isn't effective over and above what we've done before, and which we must now be doing really well going forward.
Fraser?
I'm assuming with a pause, you might be referring to me, Ian. Yeah, I agree with all that's been said. My main concern at the moment is we don't have any high quality evidence for any aspect of the disease. And the problem that even Jonathan Van Tam said in his newsreel that we don't even know if you've had it once, if it's going to protect you from further attacks from the virus. So this SD-CEP review has to happen as soon as possible. And then we can start directing practices, hospitals, and basically public income to be spent on something that will help us, because at the moment the whole economy of the country is struggling, and we don't want to be spending money on things that are because we think it's good practice, but there's actually no evidence for it. So I'm just hoping this SDSEP review will happen quickly.
Thank you, Chris. I would agree with that, but I think there was an interesting comment by Tricia Greenough, who was saying that COVID-19 is this nemesis of evidence-based practice, that at the present time we can't wait for the evidence to come forward, and we need to make pragmatic, common sense, sensible decisions to get healthcare back, to get dental practices open again and provide services for our patients. And I guess it's trying to get that balance of risk and just finding the sweet spot between limiting the transmission of the disease and the risk to the patient, but getting the dental economy back up and running again. So, Simon, do you have some further questions you can share to the panel?
Yes, indeed. We have a number of questions about differentiation between virus-free and COVID-19 positive patients. And I suppose the general question that comes out of that is, do you anticipate testing prior to seeing a patient being important, and what are the different ways in which positive and virus-free patients might be treated?
Mike, do you want to kick off with that as the oral med consultant?
Yeah. So I think there's a challenge. So if you're a patient and you're asymptomatic at the moment, we can still have pre-symptomatic and asymptomatic people who may transfer the virus. So it will be about doing a risk assessment in terms of have family members recently had COVID. The patient may themselves have had a test. The challenge with testing is not 100%. And one of the challenges with testing is if it's sent through the mail, the patient has to do a self-test. Actually putting a swab into your nose and oropharynx is not the most pleasant. And so there may be variation in sampling that feeds into the reliability of that testing. So I think testing is not necessarily universal panacea. We've seen now that they're rolling out an app and trialing it in the Isle of Wight at the present time, which pings if you've been in contact with someone who's had COVID, known to be COVID, and it then suggests that if you've been in contact with someone, you take forward action to have yourself tested and to see whether you have contracted the infection. Those will all feed in and help us to reduce the amount of infections in the community. I think the big point about if people are having the app and if people are tested, it will still be really dependent on Public Health England contact tracing. So there will be track and trace, and then if there are outbreaks in particular pieces, to close that down. So testing will help us a bit, tracking will help us. You are going to have to do a risk assessment of your patients, as I say. Have they had a fever? You know the two cardinal signs of fever or cough. To that, some people would add having sense of taste or smell changed, and we may see, there is evidence to that, whether that's adapted into the app. But it's going to be a changing landscape as the level of infection within the community changes. And the other thing to bear in mind is, from the point of view, as Roshni rightly said at the beginning, I think, we need to reassure our patients. And partly one of that may be that they may wish to know whether we have or have not had COVID and whether we are or aren't clear. And as you'll know, healthcare workers can now ask to be screened. If you're a healthcare worker in primary care with symptoms, you can send in either through the portal or go to one of the drive-through centres. If you're in secondary care, you may well be asked for that, be able to ask for that test or be asked to be tested within your hospital.
Thanks, Mike. There are sensible recommendations and advice. The elephant in the room is the cost of delivering the enhanced services. And although the tests, the cost of that may be carried by the NHS, I guess it's still the time that it takes to deliver it, the staff that will be required, documentation. It's also the throughput of patients if we're following surgeries. There are a number of issues that I guess keep springing up. that's a huge challenge for the NHS, and it needs to be appreciated that it's going to be much more costly. But it's even more of a problem, I guess, within the private and mixed sector, where patients will need to carry the majority of that cost. But so Andy, you're nodding. Can I bring you in there?
Yeah, thanks for that, Ian. Yeah, Mike makes some good points, really. You're absolutely right. Testing, tracing, treating was the first thing that came in when we had the COVID and that. And as Mike said, having a test for the active virus, you have to have the active virus particles within your nasopharynx or indeed your pharynx. And having a swab stuff right down the back of your nose is not particularly pleasant. The other thinking that they're looking at is obviously the antibody test. And they're talking about having almost like a health passport or a COVID passport. And you would carry that around with you to see whether or not you had it. Now, the problem they've got with the antibody test now, I know there's just, again, it's coming in daily, there's new tests available. The problem that they had was the sensitivity and the specificity. And if something's only 90% specific or 90% sensitive, you're going to get a lot of 10% false positives and indeed false negatives. So there's going to be people out there thinking that they've had the virus when they haven't had the virus, and vice versa, basically. So we've got to be very, very careful about antibody testing. And I think that's why PHE and indeed the government have been very, very reticent about implementing an antibody test at the moment until they can get that sensitivity and that specificity up to near as 100% as positive. Then that may well be able to help us deliver dentistry, knowing the COVID status of the patient. But as I say, I think it's just, I mean, it's not a long way off, but I think there was a team in Switzerland who'd come up with an antibody test, which they can deliver something like 3,000 tests a day. So maybe the age will come is when you come to your dental practice, you will have a finger prick test, much like you do with your INR now, and you can have your COVID status checked as well. Or indeed you carry around a health passport. But that's got a huge lot of ethical issues and moral issues when you start wandering around with health passports and stuff like that, because they're wanting health passports for everything basically. But that's something for wider discussion from an ethical and moralistic viewpoint.
Roshni, if I come to you work most of your working week in practice. In terms of the implications of testing and some of the recommendations that are being made, are there practical concerns for you there?
In an ideal world, of course, we'd like to know the COVID status of our patients. However, as you say, it's the practical implementation of that in a practice setting. If we wind back to pre-COVID and the throughput of patients coming into many practices, it's simply, one would simply wonder how that would happen in a post-COVID state. And as Ms. Edwards had said, the specificity of some of these tests can be questionable and may mean that we start to make decisions about our patients and how we practice on some tests that aren't particularly giving us the right results. So I do have concerns about the implications. Of course, if it was a perfect test and it allowed us to practice with confidence, then that'd be great. However, I have concerns about how we use this in practice and the sustainability of it, really, as well.
Fraser, if I come back to you.
Honestly, there's nothing really to add to this, because as they've made clear from the outset, the antibodies will have false positive, false negatives, and the testing will have false positive, false negatives. And it's managing, if you like, more in the epidemiological state where we are with the disease. The practices, I really do have concern for the future, but I'm sure we will come up with a strategy, because we've dealt with viruses like this in the past. For those that can remember, certain other viruses came into the dental profession, had major impact on the way we worked. We've dealt with them, we've moved forwards, and we still deal with patients in a very effective and efficient way as a profession. And I just see in many years to come the same thing. But what bothers me is how we actually get to that point. But I'm sure we will get there.
Albert, in Ireland, you're slightly further ahead of us in terms of reopening practices. Is testing and tracing an important aspect within the Republic?
Thank you very much, Ian. I mean, in relation to the practices in Ireland is concerned, I think that the testing status is very similar to what we have in the UK. A lot of the tests that is around using the PCR tests there, the sensitivity and specificity is not very, very high. So there's negative, false negative, false positive there. And there are different ones going on, moving on with increased efficacies around, but it's only one of the tactics in relation to the problem that is around. But I think that the slight difference on that is that someone may arguably say that they have never been closed down, because the guidance as such in the Republic of Ireland was not specific enough to close down all procedures like AGP procedures that we would say no, not to go ahead. And so that's the situation that faced in that situation is slightly different, that some practitioners, minority maybe, never completely closed down in the first place, and they may group together in groups of a few to offer emergency dental services, and emergency dental services may still or might still be arguably exists within the health service sector there as such, which is very, very different from the health sector in the UK. So the situation there is very, very different to this extent. However, with the lockdown slowly coming to a close, with the Irish government publishing the 5-point plan, each going 3 weeks apart in relation to monitoring what the lockdown would be, phase 1 to do this, and 2 and 3, that there's hope that it's slowly coming to the end. But the caveat is that it could be changed at any time, depending on whether the progress is actually in accordance with what they are planning or not.
Simon, have you got some more questions coming in?
Oh yes, plenty more questions. There's a group of questions around training and preparedness for practice, and inevitably a number of people concerned that they're not able to get the initial clinical experience to be able to enter the dental workforce, or at least anticipating severe disruption to that. And maybe the panel have some thoughts on how they might be supported.
Okay. I know, Mike, if I turn to you first, your thoughts around, I guess this is around undergraduate and dental foundation training.
So in terms of undergraduate trainees, there was a very helpful meeting between all the stakeholders, which we happened to host virtually, in which a document was published, or a statement was then published, which really is a very much, if you like, a risk-based approach there. So the first point of that is that the dental schools will actually determine those students who they think are ready to be safe beginners already. Obviously, COVID came towards the end of the current year's graduates. And so what was put in place is a process where undergraduate schools will make the first judgment, those people will take their exams, and we will then share their undergraduate portfolios with their training program directors, so that in areas that might have been felt to have been relative weaknesses, but nevertheless the safe beginner, could be approached during their foundation training year. There's also a proposal to give them, if you like, upskilling again, or reskilling, or re-confidence building, I think, as much as anything, for those who've not been clinically active for several months before they enter foundation training. Anyone who's been in practice will know, even when you've been on holiday for 2 or 3 weeks, you're not quite as sharp on day one as you maybe were just before you went. I think in terms of dental core trainees, there was great confidence that those current foundation trainees who are coming to the end will have done 7 or 8 months of relatively intensive foundation training, and they will progress based on both their experience, but also the opinion of their trainers who've been with them, obviously intimately involved in their training over the year. So I think they're both the exiting undergraduates and those who are going from foundation training into dental core training, and indeed those coming out of dental core training, are fairly well catered for. I think the one that we would look further to is, with ongoing disruption, it'll be the 4th year students at undergraduate school who've missed several months already and may face disruption going forward into the Christmas term. So the undergraduate schools are actively involved in how they will collectively and individually support their students to ensure that they have the opportunity to not only make up that time, but also have alternative methods of doing upskilling and acquiring the skills that they need to indeed graduate next summer as safe beginners.
Thanks. Roshni, I guess you're the closest to have completed dental foundation training. And looking across the panel, the rest of us probably wasn't necessary for us to do that. I wonder what your thoughts are, that if what could be put in place to support young practitioners who are maybe coming out with slightly less experience than has happened previously.
I think the balance will have to be between the amount of time that the trainers will get to spend with the trainees to close that gap effectively. Obviously, there is a lot of clinical activity they would have missed out, but at the same time, the trainers will have their own pressures as well. And I think the way I remember it as a foundation trainee was that we had a number of study days in place during our foundation training year. And I think as many of them that could be hands-on in that training year as possible to help the practitioners develop any clinical skills that they would like to develop or have certainly missed out on would be a welcome for the trainees, and will also reduce some burden on the trainers. I think it's striking that fine balance between the trainer and the trainee, because both will be under their own separate pressures, and the best way in which we can reduce some of that pressure on each of them would be, I think, a welcome for the trainees and the trainers together. So I think it's using those study periods and the study days that we had to facilitate as much clinical activity as possible. I think would be a great benefit.
Simon, as we move to the last 10 minutes or so, have we got some other questions? So maybe some quick fire questions, although not that quick with the delay that I've currently got. Yeah.
Yes, inevitably, people are asking when are they going to be able to open. Specifically, are private practices able to open if they can demonstrate they meet various requirements? And what is the role of the CQC and GDC in this decision-making?
Okay, well, if I ask the panel maybe to answer, to try and cut the time lag. Okay, Mike, can I ask you to take?
Okay, so the answer is that we will need to wait until the regulators, under the guidance of the chief dental officers each of the 4 nations, determine that we can reopen. And that will be a decision that they make based on evidence. And it will obviously, as I said before, have to be balanced against the evidence base around where we are with the pandemic. So this is not just about what is the environment in your surgery and have you got all the appropriate infection prevention and control measures in place. This is also about the impact of footfall and movement of people around the country, be it dental practitioners, be it dental healthcare professionals, be it support staff within your practices, be it also the patients. The mere fact that we start working means we move more people around, and we therefore increase the risk of raising the transmission rate within the community. So just because we are ready to go does not mean the country is ready for us to go. And there will be a balance to be had between those two tensions. And it's not a decision I would necessarily want to have. I think it's a really challenging decision. I think it's really challenging for practitioners who are desperate to get back to work and care for their patients, and indeed for patients who would like us to care for them. And I take my hat off to the urgent dental care centres that are doing the best they can to try and deal with the challenges that they face at the moment, and to the patients. But I think it is a much bigger issue than dentistry in this situation. It will be about when can we safely open dentistry, not because of the environment within the dental practice, but because of the environment within the country as a whole, and how us opening feeds into that. So it's a difficult challenge. And I think Albert might like to comment on where healthcare opening was within the Irish plan, because I think that's a useful, I'm not saying England or Scotland or Northern Ireland or Wales will go the same way, but if you think about where Ireland is, it was on a 3-week timeline, 5 stages. And Albert, you might like to take over where dentistry or where healthcare sits in that process.
Yeah. Thank you very much, Mike. In relation to Ireland, my understanding is that the plan has been published by the government, a 5-phased plan, starting to be implemented in about 10 days' time of the start. In the 5 phases as such there, the first phase is very, very much a semi-lockdown phases where people can start going out and gather in small group with a lot of restrictions, and then slowly it will go with review processes. The thing about the 5 phases, looking at that, the 5th one, if it all goes well, would begin end of July, beginning of August. So there are plans ahead. The trouble for healthcare professionals is that none of the healthcare provisions have been entered specifically in any particular plan as such as to which phase that there is. My understanding is that there are discussions, certainly the chances now offer of discussions between the Irish Dental Association, representing the 2,000 dentists practicing in Ireland, and the Department of Health and the government in Ireland to say where dentistry or where healthcare should fit in. There's speculation there that it should be in the 3rd phase or so, which is about 9 weeks away. But there's a lots of uncertainty with it, a lot of ifs and buts. So they're still slowly coming down the line, slowly saying that we're not very sure. We think that by such and such a state there, the viral loading around the community is below a certain sum, so that we are going to open up as such, in view of the fact of the limitations of a lot of those that we've already identified against the practice, against the risks.
Thanks, Albert. There's clearly a real challenge for particularly those in general dental practice with the pressures of getting back to work in terms of the financial aspects of that, as well as trying to protect their patients, their staff, and the wider community. Andy, I'm interested in your thoughts, certainly from a secondary care perspective in Max Fac.
Thanks for that, Ian. Yeah, I mean, looking at it in the bigger picture, I think once this rapid review's taken place, I think we'll be in a slightly better place. It's uncertainty at the moment, and that uncertainty breeds anxiety, and that's in this area, anxiety is at the forefront of everybody. I think there has to be a robust SOP in place now, whether it's a phased return for practices to come in, carrying out non-AGPs, for example, in certain practices, carrying out AGPs, whether that's the urgent dental care, I don't know, but I see it being as a very much a phased return. And standardise. In the secondary care sector, we've, I'm slightly anxious about the fact that we are losing a lot of our 2-week referrals. I have not seen in the last 5 weeks 1 2-week referral come in from a general dental practitioner for oral cancer. These patients are out there, they are somewhere. They are not going to their general medical practitioners, because obviously I triage them as well. Last week I had 3 2-week referrals, and they were from general medical practitioners. Normally in a week I would have 12 to 13. So there's a huge percentage of these patients out there walking around with potential malignancies, which are, by the nature of a malignancy, getting bigger, and by the nature of a cancer getting bigger, potentially untreatable, or potentially subjecting the patient to a more invasive type of operation with major reconstruction as well. So that has got a significant concern for me, and I suppose I'm slightly biased, and I'm just very keen for practices to open up, whether it's just for assessment only, and I'm surprised that the government, they put these conditions down for the urgent care, that they didn't put 2-week referral down. And that took me by surprise. They put things like down bleeding and pain, but they didn't put down suspected cancer or suspected malignancy. And I think that needs to be addressed as pretty much as a matter of urgency, because the longer it goes on, whether Albert goes on about it, it might be another 5 or 6 weeks. That will have a major impact basically on when and it's all of a sudden we'll be flooded with it. I think Fraser wants to bring something in basically.
Yeah, thanks for that, Andy. I mean, I just wanted to say that there's a lot of orthodontists think because we don't do aerosol producing procedures, they can actually get on with simple orthodontics. There is potential for that, but the British Orthodontic Society guidelines come out on the 4th of May have made it very clear. Most processes do provide that. And I've also heard, for example, that some oral surgeons want to do elective extractions. I mean, it must come back to what Mike has said, the risk-benefit analysis. And the other point everybody must remember is we can't track where a person has caught the disease from yet. And if you were to open up and somebody went to your surgery and caught the disease, other than when the risk benefit of, for example, oral cancer outweighs your attendance, you can't then say it was you that didn't give them that disease. And are you going to really professionally reflect on that as a positive outcome, that the patient caught something potentially in your practice? So certainly orthodontics and any elective procedures at the moment shouldn't be undertaken.
Thank you. Simon, some final questions from you?
Yes, indeed. There have been a few questions about the variable risks for members of the dental team with preconditions, in particular age groups, or other factors that may affect their vulnerability, and what reassurance you can give of the support and protection for them.
Thanks. Albert, can I turn to you first?
Yeah, I think that there are relatively little evidence as such, because the presenting symptoms, I understand, of COVID it varies hugely, and whether there would be a proliferation and a rate of proliferation where multiple organs are involved. Say, for instance, there's still unexplained incidents that the mortality rate is a lot higher on those which or who develop secondary blood clots, and they don't actually know what the reason for it. So we don't actually know whether in a certain condition that you're more predisposed to that or not. We know that there are certain predisposing factors like diabetes, high blood pressure, or certain genetic ethnic groups as such that we do, but the actual patient specific situations we don't know. So all we can do is to take universal precautions, not to take any risk there as such. So going back onto what Mike and Fraser and Andrew and Ian and Roshi said, then risk assessment in relation to the knowledge is very, very important, because there's still a lot of things that we don't know. We won't be able to say, yes, definitely go ahead with this, because there are certain proportion of the population who are very, very susceptible to these problems, and we haven't got any means of treating them as yet.
Thanks, Albert. Would anyone like to add to that before we start to wind up?
So if I could, Ian, I'd say there's quite a lot of, you've seen quite a lot of debate in the press and on the telly around Bane, so-called Bane groups. I think one of the things to consider is we know that your gender is important. It's generally males who have worse disease and a worse outcome. We also know there is some link as well with age and ethnicity. So it seems to be for over 55 in the Bane group, predominantly when they have an underlying health condition. And those health conditions, as you'll be aware, they seem to be around hypertension, cardiovascular disease, diabetes, chronic renal disease, chronic obstructive pulmonary disease, and for everybody, obesity. So I think those are all things that we need to take on board. So many of the panel are at higher risk purely by their gender, others by data of comorbidities. And I think where the Bane piece, the data isn't clear at the moment, because in some of those underlying health conditions are more common in certain ethnic groups. So that won't really get worked out initially. But I think that people need to be aware that if you have comorbidities within yourself or your workforce, that may confer a greater risk. And I think there's also be some evidence now around pregnant females over 28 weeks may be at a greater risk. So they're all things to bear in mind when we're looking to reopen surgeries. We need to have an open discussion with our workforce around that, and around, you know, are there any risks? Are there any factors that may impact on you or concern you?
Thank you, Mike. Well, that's that hour has disappeared very quickly. I'd like to thank all the panelists that have contributed this evening, and in particular those that have tuned into the webinar, a record number, and have put their questions forward. And it's to reassure you, although we may not have had an opportunity to answer all your questions, that is a really useful resource for us as deans and our team behind the scenes to actually work out what the challenges are going forwards, and we can then feed them in at a national level. Unfortunately, you know, with a webinar like this, we do focus a bit on the challenges ahead, but I have no doubt that, you know, dentistry will come through this, and there is light at the end of the tunnel, but we will get there quicker if we work together and we collaborate, as the colleges are doing and many other organisations and societies are doing as well. And there has been a lot of focus on preparing for a return to practice around PPE and AGPs, but as the panelists have alluded to, it's much, much more than that. And although it's important that we get our stock in place, it's much more about the training and the preparation and the understanding of how you can use your practices and your facilities to deliver safe care. So there's a lot to be done over the weeks ahead, and certainly all the colleges will be looking to put resources in place and to help our members and the wider dental community to have a safe return to practice. So thank you very much for tuning in this evening. My apologies for the delay from Devon, and I wish you all a safe few weeks ahead. And we have a further webinar planned in 2 weeks' time. And I hope, certainly from the Dean's perspective, we will have more that we will be able to contribute in terms of advancing knowledge, perhaps a bit more on the evidence base. And we have got a group based in England at the moment that are looking to produce advice and guidance. There's cross-representation across many bodies, and that's been led by the Faculty of General Dental Practice and the CG Dent, with input from FDS as well. So I hope we will be able to come back in 2 weeks' time and give you a bit more of an upbeat message. But thank you very much indeed.